Great. Hello, everyone. It's my pleasure today to introduce our visiting speaker, Dr. Lillian Min. She's coming from University of Michigan, where she's an associate professor in geriatrics and palliative medicine and the ambulatory care chief in geriatrics. She also is 5/8 VA. She received her medical degree from UCLA before doing internal medicine residency at Bayview Johns Hopkins. She went back to UCLA for her clinical geriatrics fellowship and did her research training, getting a Master's of Science in Health Services research from UCLA School of Public Health. And she's board certified in internal medicine with certificates in geriatrics and hospice and palliative care medicine. She joined faculty at UCLA in 2005 and then moved to University of Michigan in 2010. And she has a broad body of research, including studies on quality measures in ambulatory care, hypertension treatment, and identifying falls using ICD-9 codes. Her current VA Merit Grant studies the impact of VA home and community-based services and how that affected care for veterans during the COVID-19 pandemic. And she's also current code director of University of Michigan's new T32, which started in 2020 for age-related conditions. Her talk today is titled The Year That Was to Be, Dementia Life Expectancy Prediction in Older Adults, Independent Mobility and Function Limited Life Years. Please join me in welcoming Dr. Lillian Min.
Thank you all for having me. It's been such a great day. I really enjoyed my visit so far, and it's an honor to be able to present to esteemed colleagues in the research and clinical geriatrics field here. So the toll of dementia in the US is high at 6.9 million people with Alzheimer's dementia, and projected to nearly double by 11.2 million by 2040. The rapid growth of the age greater than 85% composes greater than 1/3 of the total dementia population now, and is projected to comprise nearly half in 2040. So what's striking to me is that 70% of caregiving cost is borne by family caregivers, and on average, a caregiver provides care to their loved one with dementia for greater than 4 years over the course of their disease. So as we all know, dementia is a disease, chronic condition that progresses in stages, and it's characterized by deterioration in memory and function. And what we're all used to using, I think the most facilely in terms of staging, is the FAST tool. We don't even think about the earlier stages, the pre-dementia stages, which is estimated to last about 10 years. Mild dementia, approximately 2 to 3 years. And we characterize that in our geriatric framework as having impairments in IEDLs or needing help with them. And then stages 5 and 6, moderate to severe dementia, characterized as needing help in basic activities of daily living, maybe lasting a wide range of 2 to 5 years. We don't think about this. We kind of track them kind of throughout. Really, the only stage that we have a hard sort of life expectancy in our sort of clinical framework is when are they end stage and when are they eligible for hospice services, because their life expectancy is 6 months or less. And we kind of understand the hallmarks of the disease when they enter that stage. But I'm going to talk to you about life expectancy in general for dementia in those earlier stages. And so I just wanted to get off the table, what is life expectancy? So do a little bit of teaching. So we're all used to looking at risk. All of our population-based studies are based on mortality risk or risk of some event happening. So the life expectancy is, when it relates to mortality, is the probability of dying for an individual when it reaches 50%. So like when we're talking to someone about life expectancy, this is the time frame over which half of people who look like you have passed away, and the time after which half of you are still alive. So what I wanted to start thinking about was, is there a life expectancy within each stage, like those earlier stages of the decline in dementia? Because knowing the life years expected in those advanced stages could be a key to care planning over the long term. It could guide informal care needs and the duration of those needs, and the timing and perhaps affordability of paid services. For example, a family who's trying to plan out the resources that they need, And so thinking about this, what is the time over which half of these patients will need this amount of care, less than that care, and half the people greater than this time, they'll still be needing those services. So same thing as in life expectancy, but the life within each stage. From a neurologic perspective, this has been synthesized by Bruck et al. Fairly recently in 2021. This was a synthesis of articles that were neurology based, so sort of rigorous neurology type of epidemiology studies where they followed patients from the time they're diagnosed or even pre dementia and tried to estimate how long they were spending in each stage. And so I was surprised to see, as I was doing the review for this project, that there actually is a duration within these stages that are estimated, and they provided some point estimates in this really nice review article with huge appendices if anyone's interested. It's this in the Journal of Alzheimer's Disease, and they do a lot of different ways of cutting the articles up into getting different duration of each stage, different types of patients, different types of clinical versus like more neurology pathology studies. So on one hand, we have research that is talking about ADRD progression in the stages, and it has to do, it's very like rooted in Alzheimer's pathology. Other causes, like, maybe we have a little bit less understanding of what those progression might look like in terms of vascular dementia. And then, patients come in different flavors with other types of risk factors that have to do with their dementia progression, like past insults, head injury, alcohol use, or depression. And then in my world as a geriatrician, my framework is rooted in decline. And so I think about a fully independent person, and then as they decline, regardless of the cause, they start developing a slower gait, frailty, then loss of their IADLs first, and then loss of their basic activities of daily living. And so, of course, if someone has Alzheimer's disease progressive, the Alzheimer's affects the way I think about a person's decline overall in terms of their life expectancy and guides my care for them. And then it goes back the other way as well. Our definition of functional decline directly informs when we say that someone has entered dementia versus MCI. So it kind of goes both ways, both these ways of thinking about life expectancy and progression. In my world, though, taking care of real world patients, I also am not just thinking about their Alzheimer's disease pathology or their vascular dementia or their mixed dementia pathology. They also have other comorbidities that are happening at the same time, both feeding into their degeneration of their cognitive function and also their overall decline. And so I have to think about them very holistically and globally. And so thinking about life expectancy in stages also has to take into account the other comorbidities that are happening. So recently, my esteemed colleagues here have published a series of 2 articles that have brought life expectancy and dementia risk into population science. So really excited to see this. And so I am now daunted with the task of presenting your own research back to yourselves. But I can't not talk about it. So we have an amazing study using the health and retirement study to study the risk of dying in patients with dementia over a long period of time study to collect a large number of patients instead of smaller cohorts. 4,267 patients in health and retirement study for the derivation and validation NHAT study in 2,404 patients. And Dr. Deerdorf and others looked at varying out timeframes to look at risk. And these health factors, demographics, health factors, functional measures, chronic conditions, did a great job of differentiating between people who are going to die and not die over 1, 2, 3, 4. They did all the different sort of time outlook. And then they followed up with another study to look at dementia patients in the health and retirement study and NHATs to look at the time that were over which they would develop a need for long-term care services, either from ADL impairment or actual nursing home admission. And so this study identified age, gender, BMI, ADL, IADL count, driving state, falls, recalling day of the week, month, and the year as being important risk factors. Also, well validated and calibrated. So my colleague, who's Bruce Kanosian, who I am starting to do dementia research with, pointed this article out to me. It's a series of articles by Stern and others, who also is in this space that I think is extremely interesting. So they looked at both total life years and the need for caregiving, meaning supervision for like most of the day, as being their outcomes, two different outcomes in a longitudinal study of a small number of patients, but over a long period of time and with very detailed number of measures, and really focused on dementia progression. They were assured of when the dementia diagnosis was done, and then followed them over time for symptoms and decline. So they use a method of organizing people into classes or types of risk profiles, kind of like latent class analysis, where you take a large number of variables and figure out different types of people to put them into different risk sort of strata. And there's over 70 of them. But these include really rich, detailed variables such as cognitive testing, behavior, types of things that are happening, and time since diagnosis, stuff that we don't have in the HRS. And they have put this into an online calculator where you can do pull down menus for all of these individual variables. And then you end up getting risk for these two different outcomes: total life year, time to death, and also time to need for long-term care, or it's like advanced sort of caregiving. And so similar to studies that use time to event, you would kind of get your life expectancy by, you draw a mental line from this 50% line, and you kind of make this mental horizontal line, and you say, I inputted a 75-year-old woman who has some like paranoia symptoms and a little bit of help for IEDLs, and I got this output. And then I didn't do any of the pull down menus because he said, you don't have to do all 70. I said, I don't have time. I don't have to do 70 pull down menus. And so you look across and you say, for this person individual, you'd have like their life expectancy is 1 year to needing caregiving. And then she pretty much was almost about to get it. And then if you draw a mental line all the way across here, you would say, almost 5 years of life left. So what I wanted to do was kind of put together in one outcome life expectancy through different stages, rather than doing one outcome and then another outcome and kind of presenting them as separate sort of models. And the inspiration for this project was a study done using EPI's data, and this was published in 2003 by Dr. Keeler and others. And the study was introduced to me by my mentor, Dr. David Rubin. He said, you should take a look at this and do something, sort of contemporary. So this is several years ago when we replicated the study in the HRS and tried to and learned this technique. And so I'll try to teach this technique to you all today. But what we're trying to do is take a look at total life expectancy, but the total life years is composed of life years spent independent, mobility impaired, and functionally impaired. And the three different types of life years add up to your total. So you actually have 4 outcomes. So we sought to update the EPI study, but not just and then the EPI study was only community dwelling, like just everyone, not just dementia. So all comers. But we wanted to do it just for dementia, for patients with dementia, and then personalize it just like that, what they did, personalize it to a person's age, cognitive status, baseline mobility, and function. And these are my co-authors, so Christine Segoli, and my analyst is Jin Kung Ha. I presented this an earlier version of this research at the AGS last year in the plenary session, everything has changed because we have a new wave of data. So I just want to add this in as a note that this method takes the most recent data that we have instead of using as long of a data as we can get so that we can make sure everyone, at least half the people, sort of have the event. We take the most recent so that we can have the estimates from the newest data that we can get due to secular changes and perhaps life expectancy. So the instant that new 2020 data came out, we said, okay, we can update this, and I'll show you the reason why we're doing 2016 instead of 2014. For those of you that weren't at my talk, just ignore that disclaimer. Okay, so this is a sample that's 8,313 people aged 70 and older in the health and retirement study who were a part of the 2016 wave. And as you all know already, the HRS is a nationally representative longitudinal survey. It's conducted every 2 years by the participants or their proxies if they're unable to. It does a very good job of collecting a comprehensive set of measures of mobility and function and cognitive performance. So this is a study about transitions. And in the next couple of slides, I'll show you how this is set up. But the the participants in the 2016 wave, that's considered to be the pre-transitional wave. And I've put them into 4 categories. So if they're independent, that means they have no mobility impairment. If they have mobility impairment, and we use the questions that would kind of get them into this category listed below. And in this category, they have no ADL impairments. And then in category C, they have dependence, meaning they need help to do one of 5 of the basic ADLs. And then there's no D because this is the pre-transitional state. You have to be alive. Okay. And then in the post-transition, that's the 2018 wave. And then there's 4 different states. So in same ABC as in the pre-transitional state, but you could also have passed away before the 2018 wave. So this is my schematic depiction of the HRS interviews that are happening every 2 years, in theory. So these are little telephones because they happen over the telephone for the most part, and every 2 years, but they're not exactly every 2 years. And then sometimes they don't actually happen. But the patients in 2016 wave are the patients that I want to that are kind of come into my sample. So you have to determine if they're going to be in the sample or not. And so the definition of doing this is that they are alive by their birthday in the calendar year 2016. And if they've died before their birthday, regardless of what happened, they're not in my sample. And there's a reason to this, is because I'm going to collect, they need to be at risk for death for 2 years. And so if they died before their birthday in 2018, then I know that they have the death outcome, and that's kind of supersedes any other interviews. All right, so there's these interviews happening. The problem is I have some missing data and I have to do a little bit of imputation. And so why not just drop those patients if they don't do the interviews? Because if we drop all the patients who are alive but didn't do their interview, then the people who are remaining will have a higher death rate because those people are alive. I know they're alive. They were alive on their birthday and they did not have a date of death yet. So I need to keep them. So some of the 2016 patients don't have an interview. Maybe they were sick. Maybe it just didn't happen. The interviews are also kind of irregular. They might not happen exactly 2 years apart. So just the cycle of the way they're happening. And so if they're missing in 2016, I'll carry forward their interview from 2014. And then the same thing for 2018. If they're alive and I don't have an interview, then I still want to keep them, but I'll walk back and do the last carried forward. If that one is also missing, then I'll use the 2020 instead. So that's why we can only go up to 16 to 18. I can't do an 18 to 2020 because we don't have the 2022. All right. And then I have an additional adjustment later on for the time elapsed between the actual interviews that I used. So this is a dementia study. Some of the patients the patients with dementia are the ones that I'm focusing on, but I still am going to take a look at the patients without dementia just for context. And so the entire population can get divided into normal, which is normal cognition, CIND, which is cognitive impairment, not demented, and then dementia. And then this is the Lango-Weir method, where we use the tics if it's the respondent, and then we use the tick score, which higher is better, and these are the ranges we use. And then for the patients who cannot participate themselves, there's a separate proxy interview asking about their IADLs and their cognition that's reported by someone else, the proxy respondent, and those are the score values that we use, and lower is better. So anyways, we use someone else's method to stratify this analysis. This is a Markov model of testing the transitional states, which is the probability of moving from one state to another. The beauty of this is I don't need to look way back in time, and we're agnostic to how long that they have been in that pre-transitional state. So I'm going to show you in the next picture, a very complicated picture, but the whole point is that every box, all the arrows coming out of it are the transitions, and all the probabilities need to add up to 1. So here's how it looks. You have an A and a B and a C. They can either stay in the same state, go to another state. There's an arrow to each other box, and they can improve, or they can get worse. And then death is an absorbing state, and you can't do anything, no matter what, after death. Okay, since I've been told that they're researchers, so I have to have some Greek, but I'm going to say it in English. Okay, so each probability is the probability of being from transitioning to the next state. All right, and if you want to design this for your own study, you would pick something with like a timer increment. And so in this case, it would be 2 years. All right, so you want to have like a standardized time where you're going to measure this transition. All right, you have to determine what your pre-transitional states are, and we've got 3 of them, and we've got 4 post-transitional states. So since the outcome is a categorical outcome, we use multinomial logistic regression as the way of modeling these transitional states. All right, so here are the probabilities that I just showed on the previous screen. It's a ratio between the 2 different probabilities that you look at one at a time. So we would look at A versus D, B versus D, or C versus D. Like death is our sort of comparator outcome. So you're predicting different odds of the different outcomes. Rate the ratio of the odds of the different outcomes. All right, that's on the left side. And then you always have age, because age ends up being like a time. It's capturing time elapsed. It's like what you're using to simulate time going by, so that we can calculate the life expectancies in this method. And so we use age, and we set it around 70. That's this term. And then these 2 terms are your baseline states. So they're indicator variables. You get 2 of them, A and B, and then to code for C, it's 0 for both of those terms. And then covariable. So I wanted to do by gender, so gender's in there. I mentioned earlier, the time lapse between the interviews to kind of do a little adjustment. And then the interactions between age, the pre-transitional state, and gender. And then, of course, all of it is stratified by the 3 cognition states. Okay, that's the end of the Greek. I'm a Stater programmer, so here's the code just for that one model. These slides will be available, I think, so you don't have to write it down. All right, and then you run the model, and then you tell the computer, I want all the probabilities for all those arrows. All right, so just tallying it up. I've got 3 baseline states, 4 outcome states, 71, 72, 73, like that, from 70 to 90, so that's 21 of them, male, female, and then 3 strata. So quick, that ends up being 1,512 probabilities that we end up modeling for our baseline model. And there's the code for that. It's very easy when you just type it into Stata. All right, and then this life table method goes on. You take these probabilities and you then use that to calculate up what the life expectancy is over a person's lifetime going forward after that. So it's taking the age and kind of iteratively counting it all up. In my world, I take those probabilities and I hand them to my analyst who does R, and she does the rest of it. She has explained to me, and I can see what she's doing, is that from age 70 to 90, we have enough sample to kind of do these transitions. And after age 90, the cell sizes get really small. And so really after that, the model is just calculating people who are still alive. And that's how you can get your total life years. And then that generates the life tables. Okay, next. What's really useful is if we know what the precision is around those estimates. So Dr. Walters and Kovinsky wrote in 2003, like the seminal article about thinking about the 25th and 75th percentile in terms of life tables. And I can't tell you, I give the lecture to my fellows and residents every time they rotate on. You have to think about a person's life expectancy. And so there's an estimate, and I show them Social Security life tables. The longer you live, the longer you live. And then you still have to further judge, are they better than normal, about normal, or way worse than normal for that age? Because that's just a point estimate. Life tables don't give you the 25th and 75th percentile, but Dr. Walters and Kovinsky, they have this article that says, look, it's not just about the point estimate. You need to know like who's in the bottom and the top quartiles. And you can get that from the interquartile range. So you have to guess, you have to put your doctor hat on and judge from your longitudinal understanding of that patient and your knowledge of their history. Are they right in the middle for their age and their situation? Or are there other, in this case, comorbidities, things like that, that kind of belie, just the functional status at this point? So are they right in the middle around the 50th percentile, or are they in the top or the bottom quartile? So we use bootstrapping. We did what I just explained to you, but 1,000 times. And so you take the sample, bootstrap it, which means you keep resampling from your original sample. It gets a little detailed, but when you do that, the HRS survey sample weights also need to be adjusted. So that's another step in this method. I send all that back to do the life tables again, and I get all of that information back. So I can give you the nice, pretty graphs in the next several sections. So when you do this, you get 1,000 estimates of each sort of data point, and then you take the median is your life expectancy, 2.5th percentile and 97.5th percentile are your 95% confidence intervals, and your 25th and 75th are your interquartile ranges. So you get 5 numbers from each bootstrap sample. All right. So our mean age was 80. There's a range of 70 to 107. There were 60% women. We had 64% with normal cognition, 23% with this cognitive impairment, non-demented category, and the 13% dementia. I mentioned earlier about the missing interview problem. So we had to impute 10% of the 2016 and 18% of the 2018 sample, and impute with the interviews before. And the range of time that I could adjust for the time in between interviews was 21.3 months, so pretty close to 24. But in all honesty, some of these were like the same interview. So conservatively, if the 2018 is missing, you roll back to the 2016. And so you could have 2016 as your pre and 2016 as your post. So you end up with a range of 0. And I think analytically, I made that 1 month to kind of make that adjustment. So 22% actually made a transition to a worse state, and 5% made a transition to an improved state. So we understand from previous data, like Tom Gill's kind of, think people don't have a constant ADL decline. They vary, and some people get better and some people get worse. And so the HRS interview is no different. You do have people who are improving. So we can see this 5%. The multinomial logistic regression actually fit the data pretty well. So when you do multinomial logistic regression, you can get an area under the receiver operating curve, but you get 4 of them because it's actually like 4 logistic regressions. So 0.85 for the outcome A, 0.81 for outcome B, 0.88 for outcome C, and 0.76 for the death outcome. And then we could get an overall AUC, which is like a kind of like a bootstrapped method of doing multinomial logistic regression of 0.81, which is pretty decent. And it was well calibrated when I repeated things across the different age groups and the cognition strata. So the multinomial logistic regression gives you these probabilities, and I'll just show you, like, this is the best case scenario. This is someone with normal cognition and who are independent at baseline. This is the best, right? So on the y-axis, the probability of transitioning, okay? And you start off with, near 1, and the outcome that I'm looking at, this blue line, is being still independent at follow-up. So if you're in a super healthy group and you're 70, which is the youngest you could be in the study, then you're most likely in 2 years still independent. Really not a lot of motion across, even to age 90, you're probably still independent at like a little bit less than 80%. And then there's this really, down near the ground here of mobility impairment at follow-up, ADL dependent or dying, at less than 10%, kind of rising to, age 90, all down at the bottom. You can't even tell the difference between the lines. It's still there. Okay, so now if you look at, I'm not going to show you all of them, but here for the dementia group, right, here's someone who has dementia but is still independent and not mobility impaired. So they can walk several blocks. They're like healthy in body, but just starting out with early dementia and being classified as dementia. So have that in your mind. Like my runner who is dementia, like he can still like go bicycling even though he's dementia. Okay, so still the probability of being independent is actually pretty good over here at age 70 in 2 years. But look, all these lines down here are not crowded down at the bottom. So the risk of being still independent is high at 70, but falls a bit to age 90. Here's death. It's not crowded down at the bottom. It rises and kind of rises to 40% by age 90. And then these 2 other outcomes down here, which is ADL dependent and mobility impairment in the red line. I tried to put the labels the same color as the line. Are down here at the bottom. So not as crowded as in the non-demented group, or the normal cognition group. And then on the right side, this is the worst off group. So you have dementia and your ADL impaired at baseline, right? So green is actually ADL impaired. So they're still ADL impaired, most likely, at 2 years of follow-up. And then there's also a chance of having died by the follow-up, which is the yellow, and that rises, and that's much higher than the other groups. And then there is a non-zero chance of actually improving. So when you're young, some of them were mobility impaired or independent even, but then that chance goes down to 0 by 90. Okay. So after sending these to my analyst to do the life table, and I converted it to graphically. So we could do it in a life table, but I like pictures. So this is how I would present. This is how I do present a life table, but in a graph with the confidence intervals. Okay. So the y-axis is your life expectancy in years. The red line is your total life years at age 70. If this is the best case scenario again, normal cognition and independent at baseline. So this person in 2016, age 70, who's the healthiest you could be, you have 20 life years left, makes sense? And of those 20 life years, 2 years, less than 2 years expected to be in ADL impairment, around 4 years in mobility limitation, and a good amount of that expected to be in independence, which is in the green. So these are stacked graphs. And so these areas represent like a declining number of life expectancy years expected to be in independence. If today you're looking at an 85-year-old who's on this side, then you have this 12 years right left to the fairly healthy 85-year-old, but of those, less of those years are independent as a percentage, and about the similar amount of years. These are fairly parallel lines for mobility limitation, ADL limitation. And then these are the 95th percentile confidence intervals that you see here. Okay. The slide I just showed you is now this upper left-hand corner. So here are I've depicted a graph of graphs where cognition is in the columns and your baseline state is in the rows. And what I just showed you is the best group on the upper left-hand corner. So I won't re-explain it, but if you look down the columns, for people who have normal cognition today, but have mobility limitation or ADL disability right now, you have a decline, fewer life years left, fewer independent years left as you go down the graph. And these are fairly smooth. You have like a bigger sample size within this column, this normal cognition. Things are pretty smooth here. This is both genders together, just to present to you, just cognition and baseline function. The middle column is this cognitive impairment, non-dementia. Fewer life years, right? Fewer independence years. And then as you go down, if you've got CIND and ADL disability at baseline, more ADL impaired years in your sort of forecast. And then in the last column are the people that we're really interested in for this project. We have fewer life years. It's not that different to me compared to the CIND in terms of the total life years, but definitely fewer independent years of life left. So here at the bottom right, here are the people that you are in the worst shape now. You have the diagnosis of dementia. You already have an ADL disability at baseline. So most of your years left are going to be ADL impaired. Maybe a little bit of improvement when you're young, but for the most part, you've got a finite number of years left. And the expectation, this is the graph where the caregiver says, how many years do I need, provide this level of care? And this is potentially where, we could be using this. So a few more years if you're younger, and it flattens out as you are getting older. These are the 95% confidence intervals. Okay, so there is some gender differences. Now, these are the prior columns, but now split up into women on the left and men on the right. So women, we know this already. It's not very surprising, but women live longer, a little longer, and spend more of their years with ADL or mobility impairment. And so that is what's depicted even in the people with normal cognition. It's not that dramatic, but if you walk across each one of these graphs, you'll see that there's a couple of years difference with more ADL impairment. It's not that dramatic in this normal cognition category. In the CIND, you see the same sort of relationship. More life years, but more of those years are spent in ADL impairment or mobility limitation than the men. And then similarly for dementia. So there are fewer, it's not as apparent with the total life years here up at the top, but the green area is smaller on the left, which is the women, in all of them except for the ADL impaired at baseline. So you have like a little more independence here, and then more ADL. You have more of both ADL and independent years for the women compared to the men. All right. So what about the interquartile ranges? I just wanted to cite one more study. There was a study that did look at present interquartile ranges for just total life expectancy. This is another very nicely done study in Seattle, 521 with Alzheimer's disease. And they presented their results, if you want to pull those, Larson, and they present Dr. Walters and Kovinsky's interquartile ranges right there along with them. You can see it in the gray is from their article. And so this article is pulling out 50th percentile and demonstrating the difference between their dementia cohort and the general cohort for each 50th percentile and 75th and 25th at these different age time points. So here for this data in the HRS, we just have to present like those 95% confidence intervals instead as 25th and 75th, and they're the exact same graph, just with smaller little hatch marks. If anyone has any other ideas of how to present this like more clearly, they look very small to me, just tighter. All right. So the strengths of the study are that we've presented a graphical or life table representation of what I think is a very global outcome. And it's an outcome that is very meaningful to patients and their caregivers. And it combines both the stages of decline due to dementia and what else is going on with the patients, and is in line with the way we understand geriatric patients in terms of function. We used data that was a survey that just used survey interview questions to determine what state. So I didn't need to send them to neuropsych testing to get them onto the tick, which graph. It's like I could, if I were to implement this, ask them questions or if I know them already, I can answer those questions and put them in the right sort of quadrant. And then the data uses nationally representative data for both the estimates and the precision. And then I could potentially use the interquartile ranges in similar fashion to what I use today to further refine my time estimate. So the limitations are that the HRS uses the questions plus the ticks and these interview questions to get people into what is a workable definition of dementia severity at baseline, but it's not. It may or may not match exactly what's happening clinically. So CIND we kind of think about it as a borderline state, but it's not necessarily MCI, but hasn't met like sort of the survey criteria for dementia. And then the states that I'm just depicting here may not actually match a purist definition of dementia staging, because in the FAST scale, like mobility limitations actually late. Whereas in the geriatric kind of framework, mobility limitations due to your arthritis and need for a cane, or your diabetes has affected your peripheral neuropathy, right? It's not the dementia that's causing your mobility impairment, it's a comorbidity. And then there's missing factors that will help you get into the interquartile ranges, but they're missing from my actual estimate. So neuropsychiatric symptoms that I would say point you to that other, online calculator. If you have something really interesting going on, use that 71, variable calculator. I've put the website into the slide if you're interested in that. And then specific comorbidities I think are really important. There's just not enough data to stratify further by diabetes, by CHF. There's not enough data. This is as far as it gets, unless I want to combine more waves together. And then dementia subtypes is not in there. We had to impute some data. And then, as I mentioned, we can't just drop the data. So some bias is in there because we're imputing with potentially like biasing toward not transitioning. So maybe some of the independence is like overestimated, I think, even though our total, I think, is preserved. And then the fluctuation in the states, right? It's like the HRS respondents might have said, yeah, I have trouble walking because I just, sprained my ankle. But then that's just a temporary state. And then like in reality, in your clinical world, your patient that just sprained their ankle would not answer that I'm permanently mobility disabled, because they know that it's just a temporary state. I'm just hypothesizing why I see so much green, even though they should be like declining consistently over time, but that's not really what happens in the real world. So this method may be overestimating like the improvement like state, because it's adding things up across the ages and giving us these expectancies that might be overestimating, I think, independent years. So how would I use this in my clinical care? So as I mentioned earlier, I would If someone has a very good life expectancy, I have them on a pathway that looks very much like uh, patients with normal cognition and and younger adults, because they have 10 or more independent years left. I'm doing a lot of cardiovascular risk reduction. I'm counseling them about exercise, social engagement, and most preventive care, provided that it's part of their priorities and that the actual thing that we're considering actually has time to benefit within that lifespan. And I'm really focusing on the healthy years. So for someone with 5 to 10 independent years, like early dementia, I'm really focusing on reducing risk of further insults due to comorbidities. So reducing medications that worsen cognitive decline and being very assiduous about that. If they drink a lot, I'm going to try to convince them to moderate it. Hearing and vision optimization. It's absolutely imperative to do advanced directives while they're still able to. And then in terms of comorbidities, again, cardiovascular risk reduction, um, careful hypertension and statin management, treating their sleep disorders non-pharmacologically, preventing their fall injury, treating gait impairment and osteoporosis, and then treating depression if it's there. And if they have less than 5 independent years, this is usually when I start talking with my patients, or they're asking, how do I, what should we do? Is it time to, get a caregiver, look at assisted living? We have a very robust social work department at University of Michigan, involving them heavily to help mobilize formal services. The patients and the caregivers are mobilizing their informal network. We're looking into any sources of home and community services that might be covered, like through their veterans benefits or through other types of sources. And for some of them, they actually are interested in the duration, but for the most part, to be honest, I'm not telling them outright. I'm actually just processing everything on my own and not actually discussing the duration. But if they ask, I'll give them, an honest, sort of estimate. And some of these graphs are in my mind, but most of it is common sense for the most part for now. We talk about home safety. There's intense attention to injury prevention, and then at the end of life, in terms of continued progression, um, um, thinking about prevention of malnutrition, and then considering hospice. We have a huge medical system with a lot of responsibilities that goes beyond me. In the interest of time, I'll sort of abbreviate some of this, but we have innovations in call center where they don't have protocols in place for dementia care. And this is sort of inspired by the guide model requirements. And we're not in Michigan participating in guide due to we're participating in shared savings right now. And so it's just not financially feasible right now, but we are trying to adopt components of the guide model for our dementia patients. So we're coming up with protocols for dementia management for that 24-hour nursing hotline, and the care navigators that we've developed for the high complexity patients in our ACO. Our healthcare system has been making a huge effort to recognize coding of hierarchical condition categories, and so that includes dementia. We still think it's undercoded. So we reviewed how many dementia patients could we possibly have, for the guide model. It was a lot lower than what I thought should be there. So I think we're still undercoding. And then I continually am concerned about our performance measures. I think we've made some improvements for patients who have dementia, like their PHQ-9s reflect some of their dementia decline. And so should we be asking a PHQ-9 of their caregiver every visit, and they come every 2 months? No. And we've implemented an item for, is it the patient or someone else who's answering the PHQ-9? There's already coding for dementia that gets you out of some of the cancer screening measures. Diabetes, we have not made any sort of adjustment. They just don't get measured after the age of 75. And then we've developed a number of innovations for improving care transitions that we are embarking on trying to implement some of the guide model principles into care transitions. And a patient care monitoring at home team is thinking about adopting like the dementia group, even though if they're not high utilizers, like some of the borderline people, like into their complex care sort of patient load. And then moving toward using life expectancy as a potential measure and of an outcome measure. And this is I love thinking about measurement. I think most of my research, the usefulness is exporting like a measure that someone else can use. And the life expectancy is a high priority for patients because they want to have more years at home and they want to have more years of independence. And pushing off pushing off entry into long-term care is something that people are really interested in, and cost due to nursing home services is part of many interventions. So I think this is an outcome that's related to many things that are happening. The healthcare system is always concerned about using the system measures that are easy to measure, such as ER visits and hospitalization. But I think in the world of dementia, we've started seeing additional like system-based measures that we can capture that are related to things that people care about, like dying in the hospital or having an advanced therapy near the end of life. But what about this as a novel outcome is time spent using sort of healthcare services for ADL care. It's a measure of the time that someone with dementia spends in ADL impairment. And so if we start thinking about dementia life expectancy in the various states, we can apply this as a measure for the duration and burden of services on individuals and systems. What I just presented to you now is like a self-reported measure, but I think what I'm interested in moving toward is finding a system-based measure to capture that same idea. And so we don't have functional measures and we don't have mobility measures hard-coded in a discrete data field that is easily obtainable. But I want to move toward that with data in our EHR that we can access and use to try to estimate how many years is this person using sort of personal care services or things that suggest that they are using personal care services. For example, in the VA, they provide all the mobility equipment, they provide the incontinence supplies, and so we can kind of gauge that these people actually are dependent. And so potentially, I think that if we could measure what your expected years of dependence are, then we can compare that to an observed. So if you were to give a treatment that is supposed to work and is supposed to help prevent nursing home admission, prevent dementia progression, give you more independence, like say aducanumab or lecanemab, then every person would have, an expected life expectancy of disability or of independence. And if you're working this IV infusion, then you should be able to, extend my independent years or extend my mobility limited years and decrease my ADL impairment or decrease my time in the nursing home. And so we could move toward an O minus E or an O to E ratio. And then lastly, all these interventions to improve dementia care coordination, I think it would be great to capture whether or not this coordination could help extend the time outside of the nursing facility. So I think a little less important about like the transitions, because if we can keep caregivers more resilient and the patients are at home with their ADL impairment and being cared for stably at home, I think that's still a win. And so I think there's still a use of looking at the ADL impaired years that these caregivers had to sort of contribute to the care of this patient. So I'm trying to get grant funded. So here's the pictures from when I took my sabbatical, and I came up with this sort of body of work and where I want to go. So this picture, this is me and I think this is Mother's Day during my sabbatical. This is what I did on sabbatical pictures. My daughter, this is a year and a half ago. She's 15 now, and this is in my backyard. So Ann Arbor is very pretty in the spring. My son learned to drive when I was on my sabbatical. He's 17. He's waiting for his college admissions tomorrow. Answers. This is me bike riding in Ann Arbor. During sabbatical, we trained to go on a trip to Hawaii and bike on the mountains. And so we were trying to get in shape for that. I went to go visit my family. So my parents live in Los Angeles. We live out in Palos Verdes. This is a restaurant out on the coast. My father is in back of me. He's 84 now. This was a year and a half ago. He's my mom's caregiver. She's getting frail, he's a demonstration of like very good chronic condition management, and extending his life. And then my mom is she is frail, so I think about her a lot, and what he has to provide for her. We're Chinese. We enjoy playing mahjong with each other. And this is from the Upper Peninsula of Michigan. Very, very beautiful up there. A little bit smaller than Yosemite that I just visited this past weekend. Okay, and then here's my movie. I'm trying to get grant funded. So I learned to figure skate as an adult. So it's like slow and hard. And so here's a video of like, this is what I think about grants. And then I just have to like submit the idea like a lot of times. And then sometimes I get lucky. So figure it out. And then sometimes I get into a sequined outfit and compete myself. My daughter is the competitive figure skater, but I'm doing a little as well.
Just to show our appreciation for you, it says the teacher affects eternity.
Oh, thank you.
And so there you go. I won't get it out too much, but
wow.
Thank you.
Thank
so,
you.
like, hopefully doesn't put your carry-on over the limit.
No, it'd be great. Thank you.
Absolutely. And I'll open it up for questions.
Yes.
Actually, maybe I'll lead off with a question.
Yes.
Answer this. Do you show those graphs to caregivers, or how do you?
I've not done anything. I presented it and I had to make a number of like reanalyses. This is a little bit different from what I presented. And I don't want to show it to people until it's been peer reviewed.
Yeah. That's the question.
Yeah.
I'm curious how people react to that, or how to best explain it, because obviously words matter.
Yes, I think that a lot of work needs to be done, and others who do this communication research and qualitative research, I think, are better equipped to like take this on. One of my grant submissions does have a qualitative component where we are asking caregivers and also people in the care team, various multidisciplinary people, about the acceptability just even of this information. We're not even at the point where I can show the picture and like say like, so do you understand this picture? I think that even the idea of being told a life expectancy of any sort is still in its infancy.
You have to go.
Yeah, and then I think potentially there is some variation in how people react, like their background, or if they're afraid of something happening as a result of like not having a good life expectancy or being denied care. Like we like Dr. Sugoli and we are very attuned to wanting this to be a tool to help people to plan and not say, limit care, but as a way to say, on one end, hey, you've got a lot of years and let's do this so we can make those years the best that we can, rather than like maybe instilling fear. I think that's kind of where I'm at. Yeah.
Yeah, when you show the graph, show it starting said here are people who are the healthiest. Did you mean in terms of cognition?
Both. So the cognition would be like one of the ways to look at them, and then their function being the other, and then ignoring the comorbidities because there's not enough data in one wave to further say like another 9 graphs with high comorbidity, another 9 with low. Like it just becomes too small to be confident. So only, yeah, in that when I said these are the healthiest of those, like say 9 boxes, it's like here are the people who are not have no impairment and they're, like mobility wise, they're fit, even with their comorbidities. Is the answer? Yeah. No, but others have. So the literature to look at would be the people who have like sepsis. There's a body literature with that. There's a body of literature of like head injury and other acute illnesses, and then the whole delirium in the hospital literature. So when they follow those people out because of after their delirium, it takes months to recover, and sometimes they don't, and sometimes there's a permanent sort of cognitive drop off because of their severe illness that they had. So not me personally, but it's out there.